All right, so welcome everyone. Hello. This is the first of 3 webinars we'll be hosting this month in celebration of Heart Month. My name is Abby Riley. I'm the manager of the Women and Heart Disease program at Mainline Health. And with me today, I am happy to introduce Dr. Erik Kelly. Dr. Kelly is a general cardiologist here and with expertise in all aspects of non-invasive cardiology, as well as advanced training in cardiac MRI, cardiac CT, and echocardiography. Dr. Kelly has a strong interest in preventive cardiology, and he is a certified specialist in clinical lipidology. So today he's going to be speaking about diabetes medications and the surprising cardiovascular benefit they may bring. After Dr. Kelly does his presentation, we're going to have about 10 minutes of Q&A. So there is a Q&A chat box at the bottom. If you want to just jot down any of your questions, we'll have about 10 minutes at the end, like I said, and I will answer probably 5 or 6 of your questions. So again, we welcome Dr. Erik Kelly, and I will hand it over to you. Thanks so much.
Abby, you can hear me okay still?
Yes.
All right. It says here, host disabled participant screen sharing.
Okay, let me make sure.
There we go. Sorry, everyone, just bear with me here. All right, Abby, can you see my slides okay?
Yes, we can.
Excellent. All right, well, good afternoon, everyone. Thank you so much for joining us here. It's a real pleasure to be a part of this program and to be able to speak with you all today. As Abby mentioned, I'm a general cardiologist here, but have a particular interest in preventive cardiology and have some additional training in lipidology or treatment of cholesterol disorders. So this topic is certainly near and dear to my heart. And who knew, several years ago that a cardiologist would be speaking on at least some facets of diabetes medication. So it's a really a great advancement in our field. So with that, let's get started here. This is what I hope to cover today. Start by setting the scene, talk, just sort of introduce diabetes and cardiovascular risk. And then we'll dive into some of the data showing these pretty surprising and wonderful cardiovascular benefits associated with, in particular, 2 classes of newer diabetes medications, the SGLT2 inhibitors and GLP-1 agonists, receptor agonists. And then we'll finish with just a quick overview of some of the recent guideline changes that have incorporated the data from these really surprising clinical trials. And again, this could be, there are whole book chapters and whole talks written about each and every one of these components. So my idea, or the objective here in my view, is to just give you sort of an overview of this topic and where the field is headed. So cardiovascular disease, as I suspect many people, understand, it's a big problem in our country and around the world. It's the leading cause of death in both men and women in the United States. 1 person dies every 33 seconds in the US from cardiovascular disease, and 1 in every 5 deaths in the US is due to heart disease. So it's a big problem. And hate to start a talk with such grim statistics, but I think the silver lining here, obviously, is that 80% of cardiovascular disease is felt to be preventable. It's why part of the reason I love preventive cardiology, and there are so many wonderful initiatives such as those through the American Heart Association, our institution as well, to try and get the word out that the cardiovascular disease is preventable in many cases, and the sooner we recognize risk factors and address them, the better off patients typically are. And so when we talk about prevention of cardiovascular disease, really what we're often talking about is the early identification and treatment or modification of risk factors. And so there are many of them, and this is not an inclusive list, but suffice to say there are both modifiable and non-modifiable risk factors for heart disease. Non-modifiable risk factors, things we can't do much about, would be obviously one's age, race, ethnicity, and some genetic factors. But there are many modifiable risk factors for cardiovascular disease, and some of them are listed here in green. So high blood pressure, smoking, physical inactivity, obesity, diabetes, high cholesterol, just to name a few. And so this is, when we talk about prevention of cardiovascular disease, as I said, a big component is really trying to identify these risk factors in our patients and then aggressively manage them. And so for the purposes of today's talk, really our focus will be on, again, diabetes, which again is a major risk factor for cardiovascular disease. So a little bit more about diabetes for those on the call who may not know a lot about it. So it's a condition where the body either doesn't respond well to insulin or does not produce much insulin or any insulin at all in the case of type 1 diabetes. And as a result of this, insulin resistance or inability to produce it, it leads to elevated glucose levels in the bloodstream. This is very common. So about 38 million Americans have diabetes. And an alarming statistic is that the number of patients with diabetes has more than doubled in the last 20 years. And this is a trend seen throughout the world and certainly in our country as well. As it pertains to cardiovascular disease, as I said, diabetes is a major risk factor. And indeed, patients with diabetes have a 2 to 4-fold increased risk of coronary disease as well as stroke. And another kind of concerning statistic is that patients who have diabetes who suffer a heart attack or a stroke are at higher risk of having more significant complications or even dying from that event. So there's an increased morbidity and mortality associated with that first event in diabetic patients, which is all the more reason why it's so important to identify diabetes and risk factors early and aggressively manage them to try and reduce the likelihood of that first event from happening in the first place. So again, full disclosure, I'm not an endocrinologist or an internist, but nonetheless, diabetes, there are many medications that can be used to treat diabetes. Many of them have been around a long time. There are some newer medications, and we'll talk about some of them. But suffice to say, again, lots of different categories that have been used and are used in certain situations. These are some of the drug classes and some of the medications that people may have heard of: metformin, glimepiride, pioglitazone, sitagliptin, relaglutide, insulin, liraglutide, and empagliflozin, again, just to name a few. Just to sort of provide some additional context, there are advantages and different disadvantages of these medications in the treatment of diabetes. This is a graph that just shows the relative effects of these medications on improving hemoglobin A1C, which is a measure of the average amount of glucose in the bloodstream or sugar in the bloodstream. And the two classes that we'll be talking about today, the SGLT2 inhibitors, on average lower the hemoglobin A1C a little more than 0.6. And the GLP-1 receptor agonists, again, the other class we'll be talking about, lower it a bit more. And then there's a spectrum with these medications. And so what we'll do now, sort of as the backdrop, is to dive a little bit deeper into these two classes, the SGLT2 inhibitors and GLP-1 agonists. But before we talk about the cardiovascular benefits that have been found with these trials, I want to take a step back and say, well, how did we get here? How did we get to a place where we were doing these trials that demonstrated these cardiovascular benefits? And it's kind of an interesting story that goes back to the early 2000s, where there were some studies, including this one that I mentioned here, done of some of the other diabetes medications or medications to treat diabetes that actually found some concerning findings, that some of these medications may have actually been associated with an increased risk of cardiovascular disease, heart attacks, et cetera. And so obviously these were concerning findings that led our governing bodies, particularly the FDA that approves medications to be used in the United States, to rethink how they evaluate and approve new diabetes medications. And in 2008, they passed down guidance that said that for new type 2 diabetes medications to be approved, the companies need to do studies to ensure that these medications are safe. Again, to hopefully prevent some of the data that had been shown previously that some of the older medications may have actually shown harm. So in order for new drugs to get approved to treat diabetes, the companies needed to prove that they were safe from a cardiovascular perspective. And so that was all developed in the early 2000s. All right, and so now with that as sort of the backdrop, let's jump into the first medicine class. So these are the SGLT2 inhibitors. And the way they work for the treatment of diabetes primarily is they result in the urinary excretion of glucose. And these are oral medications. And as I showed in that previous graph, they reduce hemoglobin A1C somewhere in the range of 0.4 to 1.1% on average. Obviously, there's some variability there. And this is a list of some of these SGLT2 inhibitors. And if anyone has watched television in the last few years, you've almost certainly seen a handful of the commercials for these medications: canagliflozin, which is Invokana; dapagliflozin, which is Farxiga; and pagliflozin, which is Jardiance; ertugliflozin, which is Stiglatro; and bexagliflozin, which is Brinzavi. And so these are some of the SGLT2 inhibitors, medications within this class. And so, again, when these medicines were developed, and they were developed to treat diabetes mellitus, because of the guidelines in 2008 that said that these companies needed to prove that these medicines were safe from a cardiovascular perspective, the companies performed what were known as cardiovascular outcomes trials. So big trials of patients with diabetes. Many of the patients, or most of the patients in these trials, also had established cardiovascular disease, history of heart attacks, history of strokes, or a history of risk factors, several risk factors for heart disease. And so they took those patients, and half of them got the medicine, half of them got placebo, and they followed them for a period of time to see, if there was a difference in how many cardiovascular events patients got. And these studies, these were big trials, lots of patients, and were ultimately published in very high-profile journals over the years. And so again, these were designed to evaluate the safety and efficacy of these drugs in diabetic patients. And what was really astounding was not only did these studies demonstrate that they were safe from a cardiovascular perspective, but to, I think, most people's surprise, they actually showed to be beneficial with regard to cardiovascular effects. And we'll go through, some of the detail here, but sort of the top line results that were so surprising to many were that when you look at sort of these trials on average, these SGLT2 inhibitor medications reduced major adverse cardiovascular events by about 10%. So that means about a 10% reduction in the likelihood of cardiovascular death, a heart attack, or a stroke in patients during these trials. And again, this was really a surprise finding, right? These were trials done really just to make sure they were safe. I don't know that many people were expecting to find that there was actually benefit by taking these diabetes medications, so to speak, for cardiovascular benefit. But nonetheless, this was a consistent finding in these trials, and led the investigators to look further. Could there be other cardiovascular benefits besides just this reduction in major adverse events? And indeed, more benefits were found. So in those big trials I mentioned, and in many, many subsequent trials, a very powerful benefit of the SGLT2 inhibitor class is its effect on reduction in heart failure hospitalization. So heart failure being a syndrome or a condition whereby people develop shortness of breath, extra fluid on their bodies that can at times result in enough symptoms or enough problems to result in hospitalizations. And so these medications were shown to result in a significant reduction in heart failure hospitalizations of about 31%, if you look at kind of all the trials averaging the data. And what was really amazing was that it was in a variety of different groups where this benefit was seen. So it was seen in diabetic patients actually who didn't have a diagnosis of heart failure at the outset, in patients with heart failure regardless of diabetes status. So having heart failure regardless of if you were diabetic or not, you were shown to have benefit. And the benefits were also seen or have been seen across the full spectrum of heart failure, from patients who have reduced pumping function, so-called heart failure with reduced ejection fraction, to patients with normal or preserved pumping function, heart failure with preserved ejection fraction. So in all of these different subgroups, and again, this is a summary of lots of data, lots of trials, there have been benefits with these medications in all of these different subgroups. Again, a really remarkable finding that, again, was certainly not expected by most when these trials were first done. So another thing that was pretty striking was that the benefits were seen very early. It didn't take years and years for many of these benefits to be manifest. And this is just one example from one of the trials, but similar trends were seen in the various trials that were performed. For those who aren't kind of accustomed to looking at these types of graphs or tables, on the y-axis here is the event that we're looking at, whether that be cardiovascular death, heart failure, hospitalizations, et cetera. So the further up on the y-axis, that's not good. And then on the x-axis is the amount of time that people were on the medicines. And so as you can see, there's a divergence of these two lines, patients with the placebo, patients on the medication, very early, within several months of the trial start. So we're seeing these improvements in cardiovascular outcomes very soon after the medications are started, and those benefits persist for the duration of the trial. So again, a really impressive result that was very consistent in these trials. So not only were some of these really incredible, cardiac benefits, but there were other benefits that were quite surprising. So one of the trials with one of the medications specifically showed a reduction in all-cause mortality. So a reduction from death of any cause by 32% over the course of the trial period. And this is sort of the graph showing this. Again, starting to show benefit early on, and that persists out to the end of the trial period. So a reduction in death from any cause, and from a, quote, diabetes medicine. Additional study has been done looking at kidney protection with these medications. And so diabetes is a major risk factor for chronic kidney disease. So it's an important thing to look at. And sure enough, again, looking at all of these trials and kind of averaging the data, there was about a 37% reduction in progression of kidney disease in these trials. Again, another really incredible finding that, again, was unexpected. And here, as with the heart failure data, benefits were seen in patients regardless of if they were diabetic. So not only do we have cardiovascular benefit, mortality benefit in the case at least of one study, but also kidney protective effect. And then finally, weight loss. And so we'll talk a lot more about this with the next drug class. But sure enough, the effect of weight loss was reviewed. And sort of taking a step back, obesity is a major problem in our country and around the world, with a prevalence of 42% actually in the United States. And obesity increases the risk of multiple medical conditions, including diabetes, heart disease, stroke, et cetera. And so in these clinical trials of these SGLT2 inhibitors, there was a meaningful reduction in weight of somewhere around 6 pounds on average when you look at these various trials. So there was also improvements in weight with these, again, quote, diabetes drugs. So you may be asking yourself, as I think we all have, how is this possible that this one medication can have so many really beneficial effects, not only for the heart, but various organs, treating diabetes, et cetera. And what I will say is that, the mechanisms are still being evaluated, but there are several hypotheses that have been put forth. And this is a slightly busy table, but one that sort of lays out some of the thoughts here. So as I said, the medication works by blocking the reabsorption of glucose. So there is excretion of glucose in the urine. And as a result, it's sort of, the medicine also acts as in essence, a diuretic. And so related to these two mechanisms, you have changes in plasma volume in the body, changes in the way that blood flow goes through the kidney. There is a reduction in blood pressure, changes in uric acid, changes in inflammatory markers, and also a change in caloric balance, which have downstream consequences that are at least postulated to result in some of these benefits that we've seen. So again, I don't think that we have a complete understanding of exactly how all these benefits have been realized, but nonetheless, there's some certainly some mechanistic hypotheses that can certainly hopefully explain some of this. And there's certainly a lot of active investigation in this area. All right, so with that, we're going to shift gears a little bit and now talk about our second class of medications, the GLP-1 receptor agonists. And so these work by a very different mechanism. And there are several mechanisms that are thought to be involved with their treatment of blood glucose or treatment of diabetes, including they result in insulin secretion in certain circumstances. They can slow gastric emptying and reduce food intake or cravings, among some other mechanisms, but these are some of the big ones. Most of these medications are injectable. There is an oral formulation as well, but most of them are subcutaneously injected. And as we talked about earlier on, there is an A1C, hemoglobin A1C reduction of somewhere between 0.8 and 1.6%. Again, there is some variability there, but that's a ballpark figure. And here again, if you've watched any cable TV in the last few years, you've undoubtedly seen a commercial or two for one of these medications. Exenatide, which is Byetta, liraglutide, Victoza, duaglutide, Trulicity, semaglutide, Ozempic, and tirzepatide, which is actually a GLP-1 receptor agonist with an additional kind of mechanism as well, Mounjaro. And so here again, these medications developed initially for diabetes because of the FDA guidance or recommendation. These companies performed cardiovascular outcomes trials to prove that these drugs were safe for patients who were diabetic. Here again, big clinical trials, patients with diabetes, cardiovascular disease, or cardiovascular risk factors given the medicine or placebo and followed to see how they did from a cardiovascular perspective. Again, same as before, these were designed for safety and efficacy, but sure enough, not only were they found to be safe from a cardiovascular perspective, but there were found to be cardiovascular benefits. So again, just like for the SGLT2 inhibitors, the top line results that were really most staggering were that there was a roughly 13% reduction in major adverse cardiovascular events with these medications, just like the SGLT2 inhibitors. And this is, again, so about a 13% reduction in either a non-fatal heart attack, non-fatal stroke, or cardiovascular death in these trials. When they drilled down a little bit more, there was really a very strong neuroprotective effect, meaning a strong protection against stroke. So 15% reduction in non-fatal stroke, 16% reduction in total stroke in these clinical trials. So something that was quite distinct perhaps from this drug class relative to the other. And here again, they looked at all-cause mortality, and there were two medicines, one in particular that showed a reduction in all-cause mortality in the clinical trials, and again, showing the data here that there was this difference that was statistically significant. And they also looked at kidney protection. And so the endpoints here were slightly different than the ones in the SGLT2 inhibitor trials, but this medication class reduced new onset or persistent protein in the urine, macroalbuminuria, which is a marker of kidney disease or kidney disease progression. So some data as well for kidney protection in these trials. But I would say, most people, when they hear about these medications and again, turn on the television, they think about or hear about the weight loss. And certainly weight loss was another major outcome seen from these trials. And, science breakthrough of the year was the GLP-1 agonist for weight loss. The first breakthrough in weight management since 2014. Could these drugs change everything? I think, again, everyone has heard something about these medications for better or worse in recent years. So this was another major outcome that was seen from these clinical trials, again, in these, quote, diabetes drugs. And so now there are actually a few of these GLP-1 agonists that have been specifically approved for weight loss in certain populations. And when you look at some of that data, again, on average, there was about a 15% change or reduction rather in weight from baseline in these trials. It's some of the data here. Again, this is average. There was certainly a range in the trials, but meaningful and pretty significant or quite significant reduction in body weight in patients taking these drugs. And really hot off the press, the most recent trial that was published in New England Journal at the end of last year was looking at one of these medications in patients who had obesity but did not have diabetes. So remember, all of the previous trials were done really primarily in diabetic patients with known cardiovascular disease. This was a trial looking at one of these medications in patients with obesity and cardiovascular disease or significant cardiovascular risk factors. And here again, what we found, or what they found, was that patients who are overweight or obese with cardiovascular disease, but without diabetes, still had a significant 20% reduction in major adverse cardiovascular events on the medication. So just further evidence supporting the benefits, cardiovascular benefits of these medications in various populations of patients. So not only did these patients achieve significant, they were being prescribed for weight management, but there were positive benefits on cardiovascular event reduction. So here again, the $1 million question: how do these medications do all of this, wonderful, have all these wonderful effects? There are lots of hypotheses, none of which I don't think there's ever going to be a single mechanism that can lead to all of the benefits, but nonetheless, some of the thoughts have to do with changes in the kidney, changes in blood pressure and blood flow in the heart artery circulation, changes in plaque structure and inflammation, and glucose metabolism are all thought, at least in some way, to be related. Though here again, really the mechanisms are still being worked out. There are lots of hypotheses as to why we're seeing these benefits. So with sort of that as the overview, the one thing I think that's helpful sometimes to provide context is, well, how do these medications stack up with some of the other medicines that we prescribe in cardiovascular medicine for the treatment of heart disease? And what you can see here, this is a graph looking at empagliflozin, which is one of the SGLT2 inhibitors, and liraglutide, one of the GLP-1 receptor agonists, and their cardiovascular event reduction relative to some of these other medicines, ramipril, which is used for blood pressure and a few other medical cardiac conditions. Icosapentethol is a medicine for cholesterol management, statins obviously for cholesterol management. What you can see is these, quote again, diabetes medicines are showing really similar, if not better, improvements in cardiovascular death reduction rates relative to some of our established treatments in cardiovascular medicine. So I think that this just frames how important these medications have become in the management of high-risk patients or high-risk cardiovascular disease patients. And so, sure enough, based on lots of big trials showing very consistent themes of cardiovascular benefit, many of these guidelines for diabetes care and cardiovascular care have shifted to incorporate this data. And this is a busy slide that I won't spend too much time going through in detail, but this is an updated guideline on how to manage diabetes mellitus in the current era. And what you can see here is that they're recommending that in patients who have established cardiovascular disease, have high risk for cardiovascular disease, have heart failure, or have chronic kidney disease, we should be considering some of the medications we just discussed because of the data we just discussed. So this is a bit of a paradigm shift in what would be considered, upfront management for diabetic patients with these comorbid conditions. And similarly, when we look at the heart failure guidelines, this is the most recent update from not too long ago. These are guidelines for patients with reduced pumping function, heart failure with reduced ejection fraction, heart failure with what's called mid-range ejection fraction, so slightly reduced, and heart failure with preserved ejection fraction, patients whose pumping function is quote unquote normal. And what we can see here again is prominently in all three guidelines, we see recommendation to consider that first class of medicines, the SGLT2 inhibitors. Strongest evidence is for the patients with reduced pumping function, but nonetheless, still a robust amount of evidence for use in the other categories as well. And so both in the diabetes guidelines and now in our cardiology guidelines, there is a shift to incorporating these medications earlier in treatment. And so finally, I'd like to sort of end with just a quick mention of this concept of cardiometabolic medicine. I think historically, many specialties would operate in silos. Cardiology as its own isolated specialty, nephrology, endocrinology, all as isolated specialties treating disease processes in isolation. And I think what we're coming to realize, is a lot of these disease processes, we need to take a holistic multi-specialty approach. And now we have medications that actually span these different specialties and span these different disease processes. So it's even more important now than ever, in my opinion, that we view patients in sort of this cardiometabolic medicine type framework, and utilize these medications to treat all aspects or multiple aspects of a patient. And so I think this is really an exciting time for us to be in this era with these types of medications. And I do think there's certainly more to be seen down the road, as we continue to explore the beneficial effects of these drugs. So with that, I will wrap up by, again, just summarizing. Heart disease is the leading cause of death for men and women in the United States. It's a big problem. Diabetes is a significant risk factor for cardiovascular disease, also a major medical condition in the United States. Hopefully I was able to provide some context as to why the SGLT2 inhibitors and GLP-1 receptor agonists have been shown to be beneficial for cardiovascular health, in reducing cardiovascular events, mortality, and helping to reduce kidney disease progression. And again, that the guidelines are now fortunately changing to reflect these cardiometabolic benefits from these drugs, which, as I was sort of saying in quotations, these diabetes treatments are really cardiometabolic treatments in the current era. And I think that's how we need to view them going forward. So with that, I thank you all for tuning in. I hope this was helpful to provide some overview and some context for the cardiovascular benefits of these medications. I'm certainly happy to take any questions.
Sure. Thank you so much, Dr. Kelly. I'm going to go through just a couple questions here that we do have. First one. So what doctors are now prescribing these meds for folks with both diabetes and heart conditions? Cardiologists, nephrologists, what doctors?
Question. And there was a slide that I was going to include that I didn't, that has shown sort of the change in prescribing practice based on specialty. And what you'll see if you look over time is the prescribing of these medications has slowly expanded outside of its traditional realm, which would have been endocrinology, diabetes specialists, internists treating diabetes, right? That's how it started. It is now far more common that these medications are being prescribed outside of an endocrinology office for the treatment of just diabetes. And so, I can't speak for individual practitioners or individual offices, but certainly in our group, we are prescribing these medications to treat patients with heart failure and certain high-risk cardiovascular patients otherwise. I think many internists are now prescribing these drugs in addition to diabetes experts and endocrinologists. And so, and at sort of back to my point about the kind of cardiometabolic health, I think this is a good thing that different specialists are now recognizing the various benefits of these drugs and prescribing them to the appropriate patients. So to answer your question, I think nowadays many different subspecialists are feeling more and more comfortable providing or prescribing these medicines. In certain practices and in certain situations, the administrative support for prior authorizations, startups, monitoring, et cetera, is still evolving. And so I believe as that continues, there will be even more people prescribing these medications. But certainly it's a growing group outside of just the traditional pathways.
Thank you so much. Another one here we'll take is that would these medications be appropriate if not diabetic or pre-diabetic, but diagnosed with CAD? Would one still take a statin?
So I would view these as separate, sort of to the statin point. I would view these as separate from a discussion of statin therapy, which is a talk obviously unto itself, very strong and important cardiovascular event reduction. And certainly my point for showing that graph of the relative, potential benefits of these drugs was not to say that those other medicines aren't important. They're vitally important, but rather to show that these newer drugs, I think, should have a prominent role to play in certain patients. So to your point, not obviously knowing specifics, as I said, there are certain patient groups who do not have diabetes who may benefit from these medications. Certainly, as I said, for heart failure, patients, regardless of diabetes status, may benefit. Obese or overweight patients with cardiovascular risk factors, there is data there. So I would view this as separate from a decision on statin therapy, which again is a talk to itself, but in patients with established cardiovascular disease by the guidelines is a class 1 recommendation that you should be on those medications. This would be separate from that in a way to further reduce cardiovascular risk. We know that patients who are well treated with statins, there's a percentage of them that still have cardiovascular events. And so we are continuing to look for ways to further reduce this, what we call residual risk. And this is a way of addressing some of that in the appropriate high enough risk patient.
Great, thank you. And I think you did mention this, Dr. Kelly, but these are FDA approved medications at this point.
Yeah, so again, for certain indications, yes. So the vast majority of these medications have FDA approval for the treatment of diabetes. And they've been shown to have these cardiovascular benefits, but their primary approval and the way they were first approved was for the treatment of diabetes. Some of these medications now have approval for heart failure. And then, as I said, there are a few medications that have approval specifically for weight loss. And in some cases, additional risk factors needed. So all of the medicines are approved for at least some indication. Yes.
Great. Yes, and for those who are asking, this is being recorded, so we will have this up on Mainline Health website, and I will have the link emailed to you. If not tomorrow, sometime Monday, but we will have this up on Mainline Health website, this entire presentation. And we'll take one more or two more questions, if that's all right.
Of course.
Is it possible that as the weight loss itself that is reducing the morbidity and mortality, is losing weight on your own sufficient, or should you also consider taking these medications?
It's a really great question. And I think there's no doubt that weight loss in and of itself is important for, frankly, overall health, let alone cardiometabolic health, improvements in glucose, improvements in cholesterol profile, et cetera. I think that the predominant theory or the prominent thought is that there are benefits beyond that would have been seen with the weight loss alone. But I think there's little doubt that weight loss is an important component to the risk reduction seen, whether it be with medications or not. And obviously, I think we always encourage and counsel on therapeutic lifestyle changes that can result in weight loss, regardless of with the use of a medication. And that's, again, there's so many benefits of weight loss aside from cardiovascular. But it's a wonderful question.